what is changing? What is changing? Since devolution, it was equity and devolution. Since devolution came in, have we resulted to an equitable Kenya? So when we looked at research on the health workers, for example, we saw that there is some positive impact of devolution towards resolving the inequalities that were present prior to devolution. Okay, but we also see in some areas we're stalling. Like when we look at the research that was done on infrastructure, we see that actually then what was being done before is still being done. Okay, so we are spending more, for example, in Nairobi and Kiambu and such counties on infrastructure, and that is the national government. So we see that devolution, because spending of health sector is driven by counties, we see devolution as a positive thing in the country, because we can tell that things are changing for the better in the counties where the counties have control. But at the national level, it's still status quo. They are spending as they used to spend. So there could be implications for that, but what we could say is devolution indeed has had positive impact on equity in this country.
Now, devolution and generally the whole concept of us changing the constitution, there was, I think, a credible belief that marginalization was a big issue in Kenya, and we needed to change the way we distribute resources as a country. Even before devolution, there were a couple of things that we were trying out to try and improve the situation. So you had, little funds here and there, CDF being one of those, very celebrated by MPs. I don't know about you guys. But that still continues even after we changed the constitution, in that there is still a belief that as we are dealing with issues of marginalization, we'll create little funds here and there. So CDF has become very big. Counties have also started trying to create their own little CDFs with their own development funds. So there is still a belief that we need to think about the inequalities that exist within the country. But the approach that we take and the discussions that we are having, as Jason mentioned earlier, is slightly different from a broader discussion that covers a broader spectrum than just the little funds and the CDFs of this world. Now, while devolution is great and those funds have their own merits, the discussion about the bigger budget and how equitable the distribution of that bigger budget is has remained non-existent, in fact, in many of the conversations.
When we were campaigning for the new constitution, Kenyan people were promised a lot of things. And most of them knew that with the coming in of county governments, all their problems will be sorted once and for all. And it became really a challenge. And for Elgeyo Marakwet, during the second financial year, we realized now that it was a challenge. And that triggered the county assembly to come up with a bill, an Equitable Development Act, which is an act now. And we were able to bring everybody on board. And I think through this act, 60% of our development budget were shared equally among the 20 wards. Elgeyo Marakwet has 4 sub-counties and 20 wards. So we shared 60% equally, and the remainder, the 40%, were shared basing on population. Of the 40%, 38% were shared basing on population. We also had county flagship projects, which we gave them 23%, poverty index 22%, the land area 8%, emergencies, we took 5% of the 40% development to go to emergencies, and fiscal responsibility, and also bearing in mind the diversity of our county.
It's a very interesting discussion, because what is equitable? Do you just divide the resources to all the wards and you start implementing projects, what are the parameters that we need to consider before doing all these things? So there are so many perspectives, but as Elgeyo Marakwet, we tried a formula, and I think that formula is working. To some point, it has some few challenges. When we talk about taking development down to the ward level, we still have another challenge. As you go down to the smaller units, you face different challenges as you go down. When you go to our wards, you will realize that we usually conduct something called public participation, where these people from the same ward come to one place and they discuss how they share their resources between themselves. We have realized one very serious issue, whereby when you are the host, for example, a sub-location is the host of the public participation process, you end up finding that sub-location getting quite a huge chunk of the money going to that sub-location, because majority of the people who participated come from the same location, that place. So I think it's a discussion that we now need to go down. For us as Elgeyo Marakwet, we are not talking about the sub-counties or wards anymore. It's now probably within the wards, because even within the wards, there will be an inequitable distribution of development or resources.
One of the good things that we did with Devolution is that we decided we needed to have a more predictable approach to how we distribute resources across the country. And across the country in these terms came regions, which are counties, and so we have a formula that guides how much money goes to each county. Now, if you look at that formula, it has a couple of things in it. So we distribute those resources based on issues such as population, how poor the counties are. We do have an equal share that we give to each county. We have something on fiscal discipline, which we are still struggling to define. We've tried, but we are not yet there yet. But also we look at the vastness of the areas. So because if you're in a wide county, then probably you need more money to distribute or to get services to people. So that's basically what we use. And I think one of the things that has been good about that is that it's a formula that is designed in a way that it ensures that you're giving money to where there is need. And so the higher the population in a place, probably the more money you need as a government in that county to provide services. But at the same time, it does have a redistributive angle to it, which is really the poverty part. So the poorer you are, the more money you get. So in those two fronts, we've made some steps, but then there is still a challenge, because when you think about population and poverty, we don't give any direct money to those things. You give money for health depending on how sick the population is. So if you have two counties with the same population, but one population is sicker than the other one, then it's really not fair to give an equal amount to both counties. So there is still a challenge in that the parameters that we are currently using are really based on proxies of need rather than the direct need that exists in these places. And so going forward, as we get into 2018 and we are thinking of revising this formula, because we have to revise it, then it will be an opportunity for CRA to try and bring in a couple of direct measures of these needs, because it means counties will be better placed to meet those needs when they are getting money that is measured according to what they have to provide.
And so, as a commission, when we came on board in the year 2011, we came up with a policy, and by 2013, we had done a policy. And in this policy, we identified areas that are marginalized. And we used a county as a unit of analysis. One, because of data. We didn't have enough data to go to lower areas. Two, that time, there was this hype about devolution, and everything was county-based. So we were carried by that weight. And so we used county as our unit of analysis. And we identified 14 counties, and they're listed there, Turkana being one of them, Mandera, Wajir, Marsabit, Samburu, West Pokot, Tana River, Narok, Kwale, Garissa, Kilifi, Taveta, Isiolo, and Lamu counties. And this we did using a lot of various approaches, as I will explain later. Now, this policy has been in use for the last 3 years, 2014, 15, and 16, to share revenue from the Equalization Fund. Remember, the role of the Commission is only to come up with a policy. Somebody else shares the policy, shares the revenues, and gives the money to these areas. And this somebody else is the national government. So we do a policy, we come up with a criteria, then hands over the criteria to the government to implement.
We've been critically looking at this formula, and we realized that this is a formula which I'm told it was borrowed from South Africa, which compared to Kenya, they've already developed their infrastructure. For example, when we come to issues like roads, a county like Elgeyo Marakwet, we are still struggling to start new roads. And using the formula to, the formula mainly focuses on maintenance of roads which are already existing, and even water projects and other projects. And of great importance to, I think, most of the counties who are present today, because you realize that agriculture is the main economic activity in our counties. And I've been trying to look at the CRA formula to see where agriculture comes out clearly. And you realize that maybe a county like Nairobi, which has the highest population, will get more money which were meant for agriculture, and Elgeyo Marakwet or maybe Makueni will receive less money which were meant for maybe irrigation and agriculture. So I think as we discuss this, we also need to look for ways of engaging the CRA and even the National Assembly and Senate, so that as we move to the next phase of, or we amend the formula, some factors are considered that will bring equity to all our counties.
When 2013, when we did the Commission of Revenue Allocation as a country, they did it without doing costing of functions. And eventually they gave us a formula, which I can say here that is disadvantageous to majority of the counties, and Elgeyo Marakwet being one of the leading in terms of being disadvantaged. So when they did that one, they didn't look at so many parameters. And I think even when we are discussing today, we should look at those parameters. When you only say you want to use population, you want to use area. In Elgeyo Marakwet, we have a serious challenge in terms of terrain. Terrain is a serious issue. We might be the same area square kilometers. We have the same area square kilometers. But Elgeyo Marakwet and a county like Uasin Gishu, a county like Baringo, a county like Nandi, we have unique features. So for Elgeyo Marakwet to do a kilometer of a road in Elgeyo Marakwet probably can cost 10 times more than a road in Uasin Gishu or a road in another county.
There seemed to be a positive impact on devolution, on health since we devolved. So from the counties that we got data from, you can see a progressive increase in the number of health workers, and even more interestingly is an increase in the proportion of the skilled workers. So that's a big plus. So you're not just hiring the lower cadre health workers, but you're also getting a bit more the specialists, the pharmacists, you're getting a bit more of the medical officers and more of the specialties like dentists and so on. So that's a big plus. And even more impressive for me is that some of the very poor counties like Turkana, we are seeing even a bigger jump in terms of the number of health staff that they have. So generally, and from the sample of counties that we got, it seems like devolution is definitely a good thing, because it's given counties or it has given the country some space to discuss what we need in terms of health services
within smaller units. And it seems the agreement in many of those smaller units is that we need to increase the number of health staff that we need. Of course, with time, we'll need to measure what kind of impact that has on actual service provision. And that's where things get very interesting, because increasing the number of health facilities, increasing the number of health workers does not automatically translate. So that's something that we have to actually see whether it will play out, because it could be that we are just building health facilities, but they are not running. It could be that we are employing people and they are all in Lodwar, not in Loima or in Kibich or elsewhere in Turkana County. So there is still some more work to do to understand how this plays out.
I want to speak a little bit more on what we have started speaking about, which is the sector of health, and how can we tell inequalities and how can we deal with them and how we're dealing with them. First, we're going to appreciate what was there before, right? What was there in the before devolution? What was there before? And then what has changed in terms of numbers, skill mix of health workers in counties? And then what has been done to, move that change? We looked at data from the Ministry of Health. We got data from data of health workers that were seconded to counties. And then we look at some data which we struggle to get on what is happening right now. What is a change in the number of health workers? We looked at a sample of counties, and we looked like approximately 10 on what they've been doing, and then 7 on what is a change in health workers' numbers and skill mix. Let's look at the pre-devolution situation. 3 things. At the time of devolution, there were certain inequalities, and we're going to look at 3. We see that there was unequal spending. There was obviously an equal number of health workers. And when we look at the distribution of county residents per health workers, was also unequal. And we also look at the skill mix at the beginning of devolution. Then now we look at post-devolution. We got from 7 counties, and what we see is an increase in health workers, a positive change in health workers, but it's not similar. So you see counties like Samburu, there's 13% increase in health workers, and counties like Turkana, for those 10 categories, 232 increase in health workers. So it's a significant increase. But the trick is just look at the numbers. Still, they don't have as many health workers as they would need for the county, okay? But there is positive change.
One of the things that devolution has done, the most obvious, is the fact that management of health services in terms of implementation is at the county level. So that means that in one way we expect, and we have seen actually, that different counties have come up with different interventions. It has also, I think, in a big way helped to locate the need, in terms of where is it that we don't have enough doctors and nurses, where is it that we don't have dispensaries. And we have seen, cases like we covered during the Equity Week around employment of doctors and nurses. You find Turkana has employed, a huge number of doctors and nurses. West Pokot has built health units and dispensaries. So different actors. But the other thing that devolution has done is that it has also, in a way, raised the stake of healthcare provision, in the sense that when there is a problem, people know that they don't need to fight to go to Nairobi. They can just go to their county headquarters and things will be fixed.
And then there's something that Marakwet County, for instance, is doing, which most of these other counties in the far-flung areas are also doing, which has really helped us with equity in terms of distribution of services. Doctors traditionally wanted to be near Nairobi or near big towns, Kisumu, Mombasa. In these areas, when you're a specialist, apart from working in the government, you can also set up your clinic and run it. And so there was no motivation for a doctor to want to stay in Marakwet or for a doctor to want to work in Marsabit. But then some county governments, interestingly, in the pay packs for doctors, which is not announced, is that they offer you like a return ticket for two in a month, like to and fro from the cities. So they lure people to go and work there with the promise that at least every month you have a return ticket to the capital city. And so that alone is something that is interesting people who have families, because at times, you've already established your family here and someone is sending you to Wajir, and you think about it, you say, let me go into private practice, okay, or you may as well just quit government. But now doctors have the incentives, and some counties pay allowances for people to work in those areas under the category of hardship allowances. So that is something that is really a plus.
And then we're seeing in counties like, I've been to West Pokot, they built a doctor's plaza, and they budgeted for that in 2015-16 and 2016-17. Same case to Samburu, they are trying to put staff houses in their county, and they're offering means of transport like their motorbikes to go to those areas that are hard to reach. And then for Elgeyo Marakwet as well, they're trying to put residential facilities for their health workers. And then within Samburu, they promoted staff just to encourage them to stay in their county. And then we're seeing that in counties like Elgeyo Marakwet, they're improving their working environment. So they're trying to attract and retain health workers through various strategies. And then there's this issue on recurrent and development share. We realized as we were looking at the budgets from these counties, for example, Samburu and Elgeyo Marakwet and Busia and so many counties, that they're struggling to keep within the 70-30 rule. What the PFM Acts provide is that you should not surpass recurrent expenditure of 70%. And most counties at 69%, some counties are even at 72% when you look at their budgets. And what it means to get more health workers is recurrent expenditure, isn't it? So what the trend has been, for example, in Samburu, in 2014, 15, and then 2016, 17, they've been spending on infrastructural projects, which means health facilities, right? So now they have all these health facilities. They've gotten dialysis equipment. They've been spending on capital expenditure. So now they are in a situation where they need to fill those places with workers, right? And what does it mean? It means you spend on recurrent, but there's this legal requirement of 70-30. What do they do to get more health workers into their county? So that's an issue that we've seen in many counties, that even if they want to recruit health workers, they're still limited by this legal provision.
I would say it is premature to limit spending like that, because it does not appreciate that different counties have different needs. Also, if we have to have, because I'm sure they had good intentions, because they didn't want with the wage bill to go really high, but it also has to appreciate that different sectors have different trends in spending, okay? So if the Act can appreciate the fact that some sectors, putting that cap or putting a blanket cap affects such sectors, to make exceptions to the general rule, that could help, or to make this last in a couple of years. We have laws that say until the next 5 years of this Act, let's spend on development, and then it can be reviewed or it can be changed or something like that, like a rotational clause. I don't know. It's an easy solution to a very difficult problem, and when you prescribe easy solutions to difficult problems, then you run into the challenge. It's not doable. Like, you have to consider all the factors.
Overally, when I look at healthcare before devolution and healthcare after devolution, when we look at it really, really closely, you realize that devolution has been such a good thing to health system in the country because of two things. One, infrastructure-wise. There are places where to get a dispensary, it would be so hard. But then post-devolution, we've had, also for political goodwill, these governors want to be re-elected. So they throw a dispensary here, upgrade a hospital there, for their own re-election, which is a good thing. Unfortunately, like someone raised it earlier, sometimes you don't think about the personnel. So whereas the infrastructure is being improved, the software, the soft skills are not being improved. The second thing that devolution has really helped us with, and it has spread it now to even areas like Kibera South, in a facility like that, you'd never find a medical doctor. But right now, we have medical doctors there. So you see the effects of devolution. There are places where you'd go and you think that the person in a white coat is actually a doctor attending to you, when in real sense, that is maybe a clinical officer. The highest, that you'd find is a clinical officer. And the community guys will be, daktari, daktari, and his word is final.